So I'm going to change gears from hepatitis B to hepatitis C and invite our next speaker up. And say a few words about Norah Terrault. Norah, as we all know, is a professor of medicine at UCSF. She did her training, including medical school and training in residency in Alberta and Toronto, and then actually did a year of liver research at UCSF, and then a master's in public health at Cal. Reading through her CV, I think it just emphasizes that Norah's level of respect in the field and numerous interests are vast. There are things that she's done far outside of hepatitis C, which is what we've been invited her to speak about today, that are of very high quality. I've been in an audience of most of these things, so I want to just emphasize that we're very lucky to have Norah speak to us today about hepatitis C and updates in therapy. So thank you, Dr. Terrault.
Well, thank you very much. Always a pleasure to be here. And I actually am going to talk a little bit about just sort of management, so I'm going to cover a little bit more than treatment. I think there's been sort of a shift just general in viral hepatitis. I do both, so certainly I think the excitement is building around Hep B and the new therapeutics there. And we sort of view, I think, Hep C as sort of largely a solved problem. But I'm going to share with you really where we are in terms of hepatitis C, and I hope you'll take away from this that we've made amazing progress, but still have some hurdles. And I'm going to focus only on new data presented at the AASLD, and I'm going to lump it into sort of 4 categories. There is more data about disease burden and especially the cascade of care, how we're doing in terms of meeting our elimination goals for hepatitis C. In the context of treatment, I'm going to focus on some new data. There was some new trial data with sort of making tweaks to the therapy we have, and we'll also have some real-world data to share. There's a lot of interest in what are the benefits of SVR. I think this is a very powerful data set that we have now going forward with all of these individuals achieving cure. And I'm going to deal in particular with new data around the issue of hepatocellular carcinoma in individuals who've been cured. And then lastly, I think kind of a hot topic is the use of HCV-positive organs, particularly in HCV-negative recipients. All right, so I'm going to start also with a case just to kind of frame all of these areas that I'm going to talk about. So this is a 61-year-old Caucasian man who's recently diagnosed with HCV after routine age cohort screening, so a baby boomer screening, and he's referred to you for treatment. He feels well, has really no limitations in terms of symptoms that might suggest advanced liver disease. He's treatment naive, very anxious to be cured. He's seen the commercials on TV. Even knows what drug he wants. That always happens. Comorbidities include a BMI of 33, a hemoglobin A1C of 7.7, and an HDL of 30. So he's got sort of the metabolic syndrome as a background. His alcohol intake is 4 to 5 drinks per week, no cigarettes or marijuana. So here it's pre-treatment labs, which you order, and these days we don't need a lot to make a treatment decision. Often patients come into my office, and if they have the baby and I can get a fiber scan in the office, we make the treatment decision on the first visit and prescribe. So he comes in with a viral load of 1.2 million, genotype 3A, synthetic function are normal, AST 64, ALT 72, and his platelets around 50,000. His ultrasound shows a smooth liver, but with increased echogenicity, like reflecting his fatty liver disease, and he's got a borderline enlarged spleen. So I'm going to toss it out to the audience because this is actually a little interactive. So is there any additional testing that you would order? What current options might you recommend for this patient? And what additional treatment options might be available in the next 2 years, and how do you follow the patient after SVR? So I'm going to try to touch on these, but I'm not going to speak much to additional testing. I'm going to say that in my office it means a fiber scan largely, because that's a nice, non-invasive way for me to gauge this patient's stage of disease and also characterize this severity of steatosis. But I do a lot of educating primary care doctors to do care of hepatitis C in more remote areas of California, and they don't have access to a fiber scan. So, using FibroTest or FIB4, APRI, serum panels can also be helpful in sort of staging disease. And in general, when we're making treatment decisions, we just need to know one thing: do they have advanced fibrosis or not? We don't really need to know if they're stage 1 or stage 2. We just need to know, are they advanced fibrosis? Am I dealing with somebody with cirrhosis, yes or no? And that influences our treatment decisions, and it also, most importantly, influences what we do with the patient after cure. Because it's the group with advanced fibrosis that really needs to remain under care long term. So let me just give you a little bit of background on sort of how are we doing in terms of, getting individuals like this gentleman identified and into care. And you have been hearing about baby boomer screening for many years already. There's a lot of hype around how we can cure hepatitis C, and yet there is still a lot to be done in terms of identifying the HCV-infected persons. It's still estimated that 50% of Americans who are infected don't know they're infected. We are getting better. You can see here, this is data that was from the Optum database, which is a large healthcare database. And you can see that, we progressively are increasing in terms of the number of individuals who've actually ever been screened. But so far, 18% of treatment-eligible patients in the nation. But you can see also on the right that we've done a lot better with baby boomers. So the baby boomers in the blue line. So clearly the messaging around baby boomers and the need to screen those that are born between 1945 and 1965 has hit its mark, because since about 2011, that group has been progressively increasing, and we're doing much better in that category. Now, part of the issue about finding infected individuals these days is that maybe the baby boomer screening and screening is not going to work. And there now is discussion about doing universal screening, kind of a one-time screen for all adults, as a way to finally sort of, in a very broad way, try to find that other 50%. And there's a lot of emphasis right now on sort of finding the missing millions is the slogan, because of this problem that we've yet to identify infected persons. Once they're identified, we also have another issue of linkage to care. So this is another large database that was used. In this database, they used 2 large commercial labs where they could see who had an antibody test and who got HCV RNA testing. And then they didn't have access to the medical records, but could see if they had a referral or if they had a prescription for treatment. So shown on the left, first of all, is among those that were antibody positive, you can see that the proportion that got an RNA test to confirm whether they were viremic has gone up. So this is comparing 2013 to 2016. And you can see that now, when persons get antibody testing, 77% of them are getting an RNA test. That actually is substantially better than 45%, which was just in 2013. So we're doing better there. But then looking at sort of to the right of the slide, where you see of those in purple bars that were HCV RNA positive, how many of them were seen by a specialist and how many of them were started on treatment. So the yellow represents the proportion that saw a physician, either a specialist or a primary care physician, and the green bar represents the proportion that were started on treatment. So clearly the little green bars are pretty small, which sort of highlights the problem. We've got improved confirmation of treatment of viremia, but we still have a low linkage to individuals who can treat. And those individuals could be specialists or primary care physicians, but we sort of fail on both fronts. And sort of understanding why it is that it's so difficult to get individuals onto treatment is, I think, an important challenge for us going forward. One of them may be that there are still rules about who gets access to treatment. This is another abstract that was presented entitled Barriers That Persist for Medicaid Patients. It goes by state, and I've highlighted California with the purple arrow. We're actually in the good group. Actually, about a year ago, they removed all barriers for patients to get treatment for the most part, meaning they took away requirements for fibrosis stage. They took away requirements for sobriety from drugs and alcohol. We still do have one problem, though, in that the prescriber, my little box sort of got screwed up there, but the prescriber is still limited in California. So there are still some health plans that don't allow even trained primary care physicians to prescribe. So that potentially is a barrier. But we are much, much better than, say, places like Ohio, for example, where really less than 15% of the patients are actually getting any kind of access to care. So Medicaid, there's very much a disparity there in terms of their access to treatment. So that is sort of a political battle, I think, that has to be fought. And then the last sort of trends that I want to show you is just who are you, when you see patients, who are they now? And I want to sort of make the point that most of the individuals that come now for treatment are newly diagnosed, which means that they're more likely to be treatment naive. So that's shown in the far bars here. So among treatment naive, we have more treatment naive individuals, we have more patients without cirrhosis, and more of those are being able to be treated by non-specialists. So really that's a good news, and I think it really points to the fact that this is treatment which I personally can believe can be done by non-specialists, and the actual kind of flavor of the patients really is allowing that to occur, because they really are patients that are very straightforward in terms of thinking about treatment. Okay, so we still have a challenge, and the main challenge is finding and linking patients to people who can treat. In terms of what we treat with, some of my formatting went a little bit wacky, but this says glecaprevir prentisphere, and this is in treatment-naive patients. So GP, I'm going to refer to it, as you know, is one of the pan-genotypic regimens. It's an important regimen in the sense that it's an 8-week regimen for non-cirrhotic patients. So it's one of the few regimens that across genotypes, if you have cirrhosis, it's 8 weeks of treatment if they're treatment naive. So very simple. And so this is looking at going now from clinical trials to real practice. This is real world data from the TRIO database. And it really is to make the point, it's remarkable how well this drug works. So you can see essentially everybody is cured with 8 weeks of treatment with non-cirrhotic disease. So again, pointing towards the fact that this is relatively straightforward. You know, it's once daily dosing, 8 weeks, very, very high rates of SVR in real world. Now, when you have somebody who's not treatment naive and they've been treated before and they've been treated with a DAA combination and they fail, then you'll see that our SVR rates do start to drop off a little bit. They're not at the 99% anymore, although they are still excellent. But again, looking at real world data, this is data from the VA, so they have a very large experience, over 573 they had 573 patients that they were treating who had previously failed a prior DAA regimen. So while there are some options, I would say that there's probably the go-to drug for patients who fail a prior DAA. In many instances, it's going to be the triplet of sofosbuvir, valpatisvir, and voxilaprevir, so SOF-VAL-VOX. That gives you really a drug from each of the drug classes. And again, in the registration trials for this drug, it showed very high efficacy across genotypes and across combinations of prior DAA experience. So how does it look when we move to the real world? So here is looking at the VA experience. So just taking you from left to right on the bars. What it's showing you is genotype 1 in green, genotype 2 in the dark blue, 3 in the light blue, and 4 is in the peach. So you can see that genotype 4, there aren't many of them. They all did very well. And all of the others are sort of around the 90% mark with some little bit of variability around that. You can see that in general, those with cirrhosis may be a little bit lower than those without cirrhosis. But overall, I think the results are quite good. They're a little less than what was reported in the registration trials, but I think overall quite excellent. And if you look at it sort of as a breakdown, for genotype 1, they seem to be generally around 95%. For genotype 3, similarly, although there is one exception to the rule, and that exception is that if patients were previously treated with SOF-VAL, fail that, and then were treated with SOF-VAL-VOX, that seemed to be a group in which we saw a little bit lower SVR rates in this retreatment database. Now, that probably needs to be confirmed in more studies, but sort of what I took home, to my practice from this study was really to think carefully about the SOF-VAL patients and how we do retreatment strategies, since there are some potential other options we might offer those patients. But again, to just say real-world data largely complements what we see in the clinical trials. Now, what about new data in terms of how we use the drugs? Well, one of the kind of key questions that we've had for quite some time is, can we use sofosbuvir-based therapy in patients on dialysis? If you read the label for sofosbuvir, so SOF-VAL or SOF-lodipisphere, if you have a sofosbuvir-based therapy, it's recommended that you not use it in individuals who have a creatinine clearance less than 30. So for most of us, that means that if we have somebody in renal failure, we don't use the SOF-based therapy. And I'm showing you one of two data sets that were presented. One was patients with renal failure, but this is patients actually on dialysis. And I think this is very reassuring data. These patients were dosed the same way as we would treat patients that were not on dialysis. As you can see here, they were treatment naive and experienced with and without compensated cirrhosis, and the SVR rate was 95%. So the SVR rate is where we expect it to be for soft valve hepatosphere for treatment naive patients. I think for treatment experienced, this is quite excellent. But the key thing here is that it was safe. Honestly, that is the main takeaway from this study, is that it seems that we can use this combination in individuals with renal failure, and at least we didn't see any treatment-related adverse events, no major safety issues. So that's important because in some instances you really want to use a soft-based therapy in somebody who might be in renal failure, although we do have other options usually. Okay. So the other sort of new data, at least new data in the sense of trying to look at the issue of things that influence SVR rates, was a study called the Anchor study, and it was done in persons who inject drugs. So this is a very important group for us to be doing treatment in, because this is where sort of the new epidemic of hepatitis C is occurring here in California and across the United States. So while we have the baby boomers, the other big group where we have a lot of new infections are the persons who inject drugs. So we have to actively treat that group to bring down disease so that we can try to decrease transmission. So this is a very important study because they studied adherence in a way that has never been done in another study. They really characterized kind of how patients were able to complete their therapy. So the first thing is you'll see that the overall SVR rate in this group is 78%. And you may say, well, that's much lower than what I'm used to seeing. And of course, you're going to see from looking at what happened to the patients on treatment that adherence was not perfect. And what they did really importantly in this study was try to understand, well, what kind of non-adherence matters? So the things that influenced the SVR rate in this study were if their viral load was greater than 200 at week 4. To me, that means that if you have poor adherence in the first 4 weeks, that might be more meaningful than adherence later. So that's one message. And then the second thing that influenced SVR rates, they were supposed to get 12 weeks of treatment. If they did less than 8, then they had lower rates of success. So now looking at the bars, you can see the difference. These are yes and no for SVR. So you can see the SVR group, if they had a viral load less than 200, at week 4 they had an 86% SVR rate, whereas if it was over 200, only 25%. If they had drug interruptions but continued the course, you can see there's a differential there as well, but not really in the direction you'd expect, so probably makes no difference. Having completed 2 or more bottles, which means kind of completing more or less than 8 weeks, that made a huge difference. And the most interesting thing for me was this idea that if they finished on time or if they finished late. So I don't know about you, but I have patients where they have 12 weeks, you call them at 12 weeks, I still have 8 pills left. And you go, okay, well, just keep taking them then. And so the idea was, you know they missed doses. You don't know when they missed them, but they finished it. They finished their course. And you can see here, if they finish their course, even if there's sort of these missed doses on therapy, no difference. So since treating PWIDs is such an important group, I think this is a really important take-home message that some missed doses doesn't seem to impact the SVR rate. You got to really try to maximize adherence in the first 4 weeks, and then I'd say missing a few doses, just get them to complete the treatment, and your SVR rates are likely to be actually very acceptable. Okay, and then probably I think the most impactful study potentially is this one, because this is looking at GP or glucophage but in cirrhotic patients. So at the current time, we have no regimen that can be used for less than 12 weeks in patients with cirrhosis. So every regimen that we have, you're usually using 12 weeks of therapy for whatever the drug is in our patients with cirrhosis. Cirrhosis being a little bit more difficult to cure than patients without cirrhosis. So this is a very interesting study because they're looking at just doing 8 weeks of GP in patients with compensated cirrhosis. So shown on the slide on the left is the characteristics. They do have all representation of all genotypes. This is a pan-genotypic regimen. And you can see that basically it's amazing. Really, in this 280 patients, they didn't have any virological failures. So they didn't have their SVR rate is lower, but it's lower because some people didn't return to get their SVR 12. There were no virological failures. So this actually has led to us in our clinic changing our protocol so that if we are thinking about using GP for patients and they have compensated cirrhosis, we've now gone from 12 weeks to 8 weeks. And then my last sort of new data from the meeting about sort of treatment options was again another GP. GP is kind of one of our newer drugs, so I think still quite a bit of activity there. But this is also an important study, I think, because it's trying to look at what to do with people who fail a prior DA regimen. So what they did here is you can see it's a little bit of a complicated study design, but they looked at GP for 12 versus 16 weeks. And in the patients with cirrhosis for the 12-week regimen, they added ribavirin. And the point here was to see if you take patients who previously failed soft lidiposphere or soft valpatosphere, could you use this GP regimen as an alternative? So this is a rather busy slide, but I'm going to just try to focus you on the main events here. So if we look I think you have to look at this by subgenotype here. So if you look at the genotype 1b, which is the middle blue bars, you can see that there really are no treatment failures, whether you get 12 or 16 weeks. So that would say to me that if I want to treat a prior soft lidiposphere, soft valpatosphere patient with GP, I would do it for 12 weeks. You don't need to go 16. But if you have a genotype 1A, you have to go 16 weeks. That really you don't get the same SVR rates unless you go longer. So that's sort of the message from this, that this is an option for us to consider in our patients. This is only genotype 1 patients who previously failed an NS5A plus SOF. Okay, so coming back to our case, he's genotype 3, and so you elected to treat him with soft valve for 12 weeks, and he achieves SVR 12. 18 months after clearing virus, he's found to have a 1.9 centimeter lesion on surveillance ultrasound. The MRI shows a 2.2 centimeter hypervascular mass with contrast washout and pseudocapsule consistent with LIRADS-5, which is compatible with HCC. So the questions we're going to try to address here is what to tell him about the relationship between his HCV and his prior treatment, because there is some controversy about that, whether DAAs may influence the risk for cancer. And then what do we do in terms of talking to him about transplantation? And in this context, I'm going to get into the issue of HCV-positive donors. So first of all, the benefits of SVR. I think this is probably the most interesting areas just to see with more and more follow-up and more people treated, the benefits not only to liver but to non-liver diseases in terms of cure. This to me is the most compelling data to treat everybody that's HCV infected and why we have to find them. So this is a study from British Columbia actually, but they have province-wide data where they can track every Hep C patient and everybody who's had a script. So the graphic on the left shows at the very top is people who achieve an SVR who didn't have cirrhosis. And you can see that their survival, this is looking at survival now, out to 4 years, is really very minimally impacted. So really you cure, you pretty much eliminate a risk in terms of survival. If you have cirrhosis, which is actually the next rundown, the purple line, that's individuals who had SVR, who had cirrhosis at the time they were treated, and you can see they do extremely well, and certainly much better than the green line, which is patients who with cirrhosis who didn't get SVR. And it's been well shown in many studies that there's about a 70% reduction in both cancer and mortality related to achieving cure. So this is more data just kind of re-emphasizing this. Here in this study, there was an 85% reduction in mortality across both cirrhosis and the no cirrhosis group. And this group from British Columbia also looked at other diseases. So shown across the top is diabetes, chronic kidney disease, stroke. All of those showed a significantly lower incidence or hazard over time in patients who had SVR versus those that did not. And similarly, on the bottom, there was also less mood and anxiety disorders. I think getting cured also has psychological benefits for sure. They didn't see a difference in terms of ischemic heart disease or rheumatoid arthritis, but just really the magnitude of in terms of its benefits to health is without doubt. And then what about this idea that you take somebody who has cirrhosis and decompensation, how many of them can you get reversal to a Child-Pugh A, so that you would never have, so you really don't have to think about them as being a future transplant candidate. Data from our clinic where we looked at 204 Child-Pugh B and C patients, which we had treated and had follow-up of just over a year. And then we looked to see, well, what happened to them at a year later in terms of where they were. So 24% of them had now Child-Pugh A cirrhosis with no signs of decompensation. So 1 in 4 achieve a complete sort of reversal of their decompensation. About 40% were still sort of in the Child-Pugh B/C class We did have deaths, so clearly patients with Child-Pugh PC are at risk for death, and some of them underwent transplant. So clearly this is a group that when you see them, in addition to treatment, you have to be moving them along the transplant pathway. But there will be about 1 in 4 that are going to be able to avoid getting a transplant because they're going to achieve recompensation, and they do so within a relatively modest period of time of 1 year. And when we looked at what predicted your ability to see recompensation in these patients, we found that an absence of ascites, and actually in another study, absence of hepatic encephalopathy, so signs of severe portal hypertension, patients who had more elevated bilirubin levels, and patients who had low platelet counts. The interesting thing also is that patients who have higher ALT levels are much more likely to get recompensation. It's partially because those patients, their injury is largely driven by necroinflammatory activity, so when you turn that off by curing them, they're much more likely to get reversal than patients who have a normal ALT level when you start. And then finally, the risk of HCC. So there's been a lot of controversy, started almost 2 years ago now, by a publication that suggested that DAAs, or getting treatment for your HCV, may increase your risk of liver cancer. So I think since that time, there has been a multitude of studies, and here are 2 more that were presented at the meeting. These are very large databases, and they make a very compelling point that there is no increased risk of HCC in those patients who achieve SVR. Indeed, it's significantly reduced. So shown on the left is the VA data, where you can see that whether you have cirrhosis or no cirrhosis, your risk for getting liver cancer is substantially reduced when you're cured. And on the right is a large data set from all of the clinical trials that were done by Gilead with their various drugs. And again, to show that the exposure-adjusted incidence rate for cancer is extremely low if you don't have cirrhosis. It's 1% per year if you have compensated cirrhosis, in contrast to, say, 4 to 5% in patients who have compensated cirrhosis who haven't been cured. The other point here is there's still a 4% per year risk of liver cancer in those who are decompensated cirrhosis when you treat them. So clearly the cirrhotic patients are under surveillance, but there is a dramatic reduction in their risk for liver cancer. And then this is sort of taking it one step further. There's also been controversy that sort of said, okay, maybe it doesn't cause de novo HCC, but if you have cancer and you get treated for your DAAs, does it increase the risk for your? And that was actually a little bit more mixed literature, but this is a large multi-center study presented at the meeting, 31 North American sites, in which they looked at individuals who had HCC, underwent curative therapy, and then got treated with DAAs for their hepatitis C, and they compared those treated versus not treated. And then they looked at the likelihood of getting, or the rate of getting HCC recurrence. And you can see by the graphic that there was no difference in those that were treated versus those that were untreated. So the message, and they used a multivariate analysis that sort of confirmed that. So DAAs do not increase your risk of de novo cancer, and they don't increase your risk of recurrent cancer, nor do, and I didn't show the data, increase the risk of the kind of recurrence, meaning it doesn't come back more aggressively if you're previously DAA exposed. And then lastly, the issue of transplantation with HCV-positive donors. So this is on the rise. Now, we've been using HCV-positive donors and HCV-positive recipients for 15 years, so that's not new. But we've now moved to be able to now giving HCV-positive donors to people without HCV. And the idea is you give them these donors, they get infected with Hep C, and we treat them right away and cure them. And the graph on the left, these are 2 abstracts that were presented at the meeting. It shows just how dramatically that practice has changed in just a few years, from 2014 to 2017. The red line, which is the one that's gone sort of exponentially upward, reflects the individuals in which it's positive to positive, so people feel a lot more confident about just doing that. But also the blue line, which is putting positives into negatives. So that also has increased, particularly in the last year. There's such it's happening so broadly that you can actually look at survival now by donor HCV status. And it's relatively limited duration of data, but in 2 years follow-up, there's no difference in the outcome of liver transplant patients, whether the donor was positive or negative. So they are now sort of saying that you can take patients who do not have Hep C, from a Hep C positive organ, and with immediate treatment, those individuals do extremely well. So the practice has gone beyond livers, and they're now being considered in other organs. And I think this is probably the cautionary tale from the liver meeting, There were two abstracts presented in non-liver patients. So these are heart transplants. And heart transplants, I mean, getting a heart transplant is difficult. So, anything that allows you to shorten waiting times is important. So this is a study. It was from the Boston area. So the first thing they show in the graphic is by doing this study where they took HCV positive donors and gave them to HCV negative recipients, that it allowed them to significantly reduce the waiting time for their cardiac patients. So clearly you're going to save lives if you don't have people dying on the waiting list. And in their protocol, they used GP as their drug. They started it on call to the OR. They treated them for 8 weeks, and all of the individuals treated were cured or were still in the follow-up phase, but they didn't have any treatment failures. In contrast, the group from Toronto presented a lung transplant experience. Now, all of these are relatively small-sized studies, as you can see. So in this study, they, again, took positive donors, put them into negative recipients. They put the lung on an ex vivo perfusion machine for 6 hours. They thought to reduce HCV RNA. In this case, however, instead of starting the drug right at the time, sort of into the OR, they started a median of 21 days after transplant. In this case, 2 out of 8 of their patients failed, so had a relapse. And one of the relapses has a high level of viral resistance, several kind of complex RASes. And one of their patients developed a form of very severe early hepatitis called fibrosis and cholestatic hepatitis. So I think that's the cautionary side of the table, of the story, which says, yes, it sounds like a great idea, but if you don't cure them, you're going to get into trouble. So I think the message from this is that you're going to probably hear much more about this, putting positives into negatives, but it's really, I regard it as still something that should be done under IRB protocols and with fully informed consent, recognizing that we actually don't know the long-term outcomes for patients as yet. So just to summarize the HCV sort of top line, I think, findings from the meeting this year. One is this issue of barriers to HCV elimination that we're still really have a long way to go, remarkably, in terms of identifying people and linking them to treaters. We now know that most of the patients presenting for treatment are actually quite easy to treat. Probably an 8-week regimen or a 12-week regimen is going to work for most patients. GP for 8 weeks can be now considered in patients with compensated cirrhosis. Oh, I should highlight that. I'm glad that it came up again. The study that I showed you of GP for 8 weeks was in genotypes 1, 2, 4, and 6. The genotype 3 patients, which are the more difficult to treat group, that study is still ongoing. So if you're going to adopt this practice, hold tight on the genotype 3. Those individuals still need 12 weeks. Retreatment, highly effective for those who have failed, but there are some, I think, nuances emerging regarding some of the groups that might be at high risk for failing with retreatment. We keep seeing more and more benefits of SVR, both liver and non-liver. DAAs don't increase the risk of HCC recurrence or de novo HCV. And transplantation using HCV-positive donors is something you're going to hear more about. I think we're still in a phase where caution is absolutely necessary.